Hello, and welcome to the Feeling Good podcast, where you can learn powerful techniques to change the way you feel. I am your host, Dr. Rhonda Borowski, and joining me here in the Murrieta studio is Dr. David Burns. Dr. Burns is a pioneer in the development of cognitive behavioral therapy and the creator of the new team therapy. He is the author of Feeling Good, which has sold over 5 million copies in the United States and has been translated into over 30 languages. His latest book, Feeling Great, contains powerful new techniques that make rapid recovery possible for many people struggling with depression and anxiety. Dr. Burns is currently an emeritus adjunct professor of clinical psychiatry at Stanford University School of Medicine.
Hello. Hello.
Hi, David, and welcome to all of our listeners around the world and in the galaxy. This is the Feeling Good podcast, episode 373, and we're doing another special recording with our beloved Matt May. Hi, Matt.
Hey, Rhonda. Hey, David. So great to be here with you both.
Yeah. Great to be here with you, Matt, and with you, Rhonda.
Super awesome.
It's like a highlight of my week.
Yeah. So I thought I'd start today by reading a podcast endorsement that a therapist sent us. And she wrote, "Hello, Dr. David. All of the podcasts are truly helpful and amazing. I was initially scared when I started to study the Diagnostic and Statistical Manual and read the symptoms of all the disorders. My first thought was, how do you even cure such symptoms? The next thought was that I won't make it as a good therapist. But after learning Team CBT and reading the book Feeling Great and listening to the podcasts and reading your ebook, they've all changed my perspective. I feel more confident. I feel more empowered as a therapist. I'm still learning to use the 5 secrets of effective communication in my daily life and with my loved ones. I wish I could meet you in person one day. Thank you so much for creating this incredible model of therapy. Regards."
Wow, that's so nice. Thank you. I really appreciate that.
Yeah, that was awesome. Well, David, do you want to explain what we're going to talk about today? I think we're going to talk about something really new that you've just created.
No, I wouldn't care to talk about it.
Okay, well then, Matt, what are you doing next weekend?
I'm just hanging out. How about you?
Yeah, me too.
The topic I've been kind of focused on is therapeutic stuckness, and like, why do people get stuck in therapy and not make progress? And I see 3 potential audiences for this. First, a lot of our podcast listeners are general public, people who have mood problems and probably who go to therapists. And so I've had many emails recently from people in the patient role. And then I hiked with a colleague on Sunday who, before, he's a very accomplished team therapist now, but before he became a therapist, he was a lay person, and he had some really chilling therapist experiences that he shared with me that were kind of sad and annoying, and I get a lot of emails from patients, sad emails say, "Gee, I've been going to therapy for so long and nothing's changing, and what's wrong? And is there something wrong with me? Or, what should I do?" And those really make me sad to read, and I often get involved in really nice email exchanges with people like that. And then also, I get a lot of therapists who come to me and say, "Can you help me?" And in fact, next week in the Tuesday group, we're going to have case consultation and practice a new technique I've used, although it's not new because I used to use it with you when I was supervising you, Matt, when you were a resident, but where you role play the stuck patient and the interactions with the therapist and then get unstuck. But I've been curious too to make a list of what are the reasons why people get stuck in therapy. What are the therapist errors? What are the patient errors? And I might publish that for show notes. But I think this is something that's practically important to a lot of people. It's also theoretically important because if we know why people get stuck, most of the reasons why people get stuck in therapy can be solved. Once you know exactly what the problem is, and we thought we'd just touch base on that a little bit in today's podcast. And I'll publish. I wrote a little document on it, and I'm going to have a much longer document later on, but I did an outline called When Therapy Doesn't Work, Why is My Patient Stuck, or Why Am I Stuck in Therapy? And I have a brief introduction to it, and I'll publish this in the show notes, but and I'll just give you the categories I've been thinking of. I've come up with 30 or 40 distinct reasons why therapy might be failing. And what do I mean by failing? Well, if it's depression or anxiety, I would say that therapeutic failure is anything other than a rapid and fairly dramatic change in symptoms. And it's especially failure if you're going to therapy over and over again and things aren't changing, your feelings aren't changing, your relationships aren't changing. And to me, change should be pretty flashy, pretty dramatic, pretty obvious. It's not some subtle kind of thing. But there are errors that occur at or before the initial evaluation, and I've got about 6 of those listed, but a typical example would be that the patient is brought in or has come into therapy not out of choice. The wife wants the husband to go in because he's drinking too much, or the parents bring their child into therapy, and it's kind of like bringing your car in for an engine tune-up, and you bring it in the morning, go back in the evening and pick it up and pay your bill. And a lot of people think that they can bring their child to a therapist and the therapist will fix the child, but then there's no contract, no therapeutic agenda between the therapist and the child, and that's doomed to failure. So that's just one reason. It's kind of an obvious one, but it's an important one. And then there's errors at the T equals testing. TEAM is TEAM, testing, empathy, agenda setting, and methods, or assessment of resistance and methods, however you want to think about it. And there's plenty of testing problems. One obvious one is that therapists cannot tell how patients are feeling. Therapists think they know how patients are feeling, but unless you're using our testing scales at the beginning and end of each session, you won't know how your patient was feeling at the beginning. You won't know how the patient was feeling at the end. You won't know how effective you were. You'll think you know, but your thoughts won't be correct. And if you're testing patients, every patient at every session, with how are you feeling right now at the start, how are you feeling right now at the end, you can tell when you're doing well and when you're not. And then when you're not doing well, you can talk it over with the patient or with a colleague and see if you can get unstuck. But there's many other testing issues that will lead to therapeutic failure. And then there's failures at the E equals empathy. Again, most therapists fail in empathy with every patient at every session, but aren't aware of it because you're not using the empathy scale that I've developed or the empathy scales that others have developed, that we require patients to do that at the end of every single therapy session. And if you're not, really getting a perfect grade from the patient on empathy, then you need to talk it over with the patient and see what you're missing, what are the inner feelings that you're missing, and use that to deepen the therapeutic relationship. Because if a patient doesn't feel understood, it's going to be hard, no matter how many techniques you use, to get a breakthrough. And then the most common cause of all is at the A equals paradoxical agenda setting or assessment of resistance, that the therapist has not recognized and does not know has not recognized resistance or ambivalence in the patient. and doesn't know how to bring that ambivalence to conscious awareness or melt it away. And so the therapist is busy trying to help, and the patient is busy resisting the therapist's pushy attempts to persuade the patient to think differently or whatever. And when therapists come to me and saying, help me get unstuck with patient X, 95% of the time, at least, the problem is a problem of resistance that hasn't been recognized and dealt with. And then there's methods, M equals methods. And if you're thinking about the daily mood log, there's at least 10 or 15 common errors people make in trying to, list and challenge their distorted negative thoughts. And I've listed a whole bunch of them in the show notes. You can read about that. And then at the end, there's other therapist errors, let's see if there are any of them here. Well, one big error that therapists make is joining a school or cult of psychotherapy. As you know, all know, I'm not in favor of any school of psychotherapy, and I would prefer that they all be eliminated, along with the gurus, the narcissistic gurus who started them and run them. And the problem is that psychotherapy should be a science-based and data-driven, like medicine. We don't have schools of medicine. And it's just ridiculous to think that your school of therapy is going to have the one answer for everyone, as if everyone needs to do acceptance, or everyone needs to do meditation, or everyone needs to do psychoanalysis, lying on the couch, free associating, and that type of thing. And this is just a lie, and it's just a myth that therapists get into. And because most therapists aren't measuring, and the science of psychotherapy is still very primitive and only beginning to evolve, we have all of these cults competing with each other. And I think that can also cause therapy to fail, because what if your patient isn't one of the ones who's going to think that acceptance or meditation are better than French fries, and it's not what they need and what they're looking for. There's so many things. In team, we use over 125 techniques, depending on what the patient's needs are and what the patient is like. But I'll just leave it at that, and then we'll dive into some examples of therapeutic stuckness from both the patient's perspective and from the therapist's perspective. And to get this started in a truly vibrant and, let me say, mind-blowing way, I will turn to my colleagues, Matt and Rhonda, to make the opening salvo here.
And as an aside, we were talking just prior to the podcast that we kind of just make it up as we go along. And but David, I was so excited to hear about what you're creating there. I think that could be incredibly useful for patients and therapists to have a checklist that they could systematically read through different problems that could be occurring.
Yeah.
Preventing them from making progress together.
Yeah.
That sounds fantastically valuable.
Yeah.
I thought of one example while you were talking of a testing error
Cool.
that caused therapeutic stuckness that was pretty fascinating. And I've had a few patients where I was working with them in therapy only to discover that there was a biological cause going on, like bipolar disorder, and causing their depression, or schizophrenia causing some of their anxiety and worry and this kind of thing. But this was early in my career. I was doing psychopharmacology and treating an older man who had become quite psychotic and frightened, and his doctors were all putting him on high doses of antipsychotics, and he was starting to have pretty significant side effects from the antipsychotics, and they weren't helping at all. And I remember distinctly sitting with his family members and talking to them and trying to understand, just going back to the drawing board and trying to understand what was going on in his life and getting to know him and their perspectives on things. And out of the blue, one of them said something like, "Oh, and he just snores so loudly. And sometimes he stops breathing while he's sleeping. And he sleeps a lot during the day, but then he'll stop breathing while he's sleeping." And it turns out he had severe sleep apnea. We referred him to a clinic, and he was evaluated, and there was this missing diagnosis. Uh, and once he was treated for his sleep apnea, his psychosis went away completely, and he was able to come off of all of his medications that had been causing side effects for him. And it was
Wow.
such a relief to his family. And so, yeah, that's maybe one of the first things to do if you're stuck, if someone's not getting better, just to return to broaden the thinking about what could possibly be causing the symptoms that we're seeing. And that's sort of a rare thing. You know, these illnesses are rare, but when they happen, they won't respond to our traditional methods and approaches.
Wow.
I think that's cool. And that's why I developed the easy diagnostic system. We don't talk about it much on the podcast. I don't promote it much, but it's a survey that I created, and really was about 10 years in the development. And what it is, it's a scale. If you're a therapist and want to purchase it, you can find it in my shop on my website. But it's a survey that you can have the patients fill out on their own outside of a therapy session. And there are just a bunch of short, highly reliable assessment instruments for the 50 roughly most common DSM so-called disorders. So it tests them for 5 different forms of social anxiety and, major depression and bipolar and, so-called personality disorders and that type of thing. And the neat thing is you can ask the patient to fill it out on their own and then bring it to you. And once you've gotten used to it and see how it works, you can page through it with the patient. And there's a diagnostic summary sheet. You can tick off the diagnoses for these 50 so-called disorders on not present, likely present, or definite, moderate, mild, definite, moderate, definite, severe. And you can do that in, pretty easily in 10 minutes once you're used to it. And you sometimes find a lot of things that that the patient has that you wouldn't be aware of if you had to spend an hour or 2 or 3 interviewing the patient to find out about all these different kind of symptoms. And that can sometimes give you, as you say, Matt, give you information that will change your understanding of the patient. An example might be somebody with feeling, depressed and lonely, someone who's been divorced, and then you suddenly see that they have severe social anxiety, and that might be something you'd want to attend to because they may want to get back into the dating scene but not know how to flirt, not know how to play the dating game, and be very self-conscious about flirting or talking to people. That would just be one very simple example of that. Another thing is that there's a lot of substance abuse in our society, and especially among people coming to therapy. And a lot of times therapists don't ask patients about that, but they'll report it freely on the easy diagnostic system. And so there's a lot of things like that can come from just not having the proper knowledge of your patient.
Yeah, I always feel a lot of relief when I've done the easy diagnostic survey, because it gives me such fantastic information that otherwise would have maybe taken 5-6 hours to get in a conversation, and that can really rack up the bill for that person, and it's just a tremendous tool. I recommend it to all therapists who want to get rapid but very accurate diagnoses.
I can tell you an example, then I want to get your input, Rhonda, on all of this too. But a woman wrote to me recently and said that she'd been going to a team therapist for 3 months or 6 months or something, and nothing was changing. And finally her therapist says, well, I don't think I can help you. And so she felt really, really devastated. And by the way, that's something I've never said to a patient. I mean, we've got 125 techniques, and there's always things you can think of and talk to a colleague, find out why you're stuck with this person. But this was from her perspective, and I asked her to tell me a little bit about it, and exchanged a few emails with her, because I felt so sad, and my heart went out to her. And it turned out that she was very kind of self-critical, and she had heard, I guess, that she was supposed to accept herself, and she was busily trying to accept herself, and she and the therapist couldn't figure out how to accept herself, and she felt like a failure. And I guess the therapist felt like a failure. Sometimes we're one, like we think we're different and the same thing is going on. And so I talked to her about two things. First of all, she felt devastated when the therapist rejected her. And so I said, well, that's something. And she also said she had trouble making friends and things. And so she felt lonely. And I said, well, this could be someone who you feel hurt, and maybe it would make sense to get back together with your therapist and, have a session and tell her or him or whatever that you felt hurt and rejected. And I've always felt that therapeutic failure is a doorway to a breakthrough. You just open the door and walk through, and you deal with it, because the failure between a patient and a therapist is often a direct expression of one of the patient's core issues, in her case, to open up and to learn how to get close to people. And by gosh, she took me up on that, made an appointment with the therapist. And I also talked to her about expressing her hurt and anger and disappointment in a friendly, non-polarizing way, to express some admiration for the therapist. And then she emailed me the next week that it was remarkably helpful and she was feeling better. And then she talked about, but I have to accept myself. And, even, acceptance and commitment therapy is all about acceptance is the answer for everything. And I've always said acceptance is great. It's one of 125 techniques that I've used or developed or learned. And it's great. It's amazing for a lot of people and somewhat helpful for a lot of people, and a total waste of time for many people. It's not the answer to everything. But I said, well, tell me, if you're having trouble accepting yourself, I said, send me a list of all the really good reasons not to accept yourself, and some of the terrible things that might happen if you did accept yourself. And then she made this beautiful list. It was just like positive reframing. Like if my self-criticism is painful, but I've achieved a lot, and that's one of the reasons I've been able to achieve a lot, and it shows that I have high standards and that I'm humble and that I'm honest about my faults, and all of this really, really great stuff. And then all these bad things that would happen if she pressed the magic button, and all of her self-criticisms and all of her negative feelings disappeared. And then she said, so what should I do next? And then I wrote back to her and I says, well, given all this list, I don't see how it make any sense for you to accept yourself. And maybe you could accept that. Accept the fact that you don't want to accept yourself. And that would be another way to accept yourself. And then she wrote back and said she was on a high because it made sense, and that she'd been, had this I should accept myself. Well, as the Buddha said 2,500 years ago, why the F should anyone accept themselves? It's a lot of horseshit. and she was just really, really feeling great. But that was, again, it was a kind of an agenda setting error that the therapist and patient together were thinking there was this thing they should do. And instead of looking at all the reasons for her negative thoughts and bringing the resistance to conscious awareness and dealing with it in a loving way. I will now shut up and let the smartest of the group and most beautiful and lovely and wonderful talk. Matt, it's up to you.
Yes, Matt, it's you.
Rhonda,
Yeah.
so yeah.
Matt, have you lost a ton of weight? Because you look like you're in great shape.
You do. Yeah.
Oh, thank you, Rhonda. Thank you, David. Yeah, I think I have lost a little weight. I've been going to these bar classes, and I just sweat profusely during them. But afterwards, I'm kind of on an endorphin high, and it feels good.
Nice.
So,
it's
nice.
called a bar class.
Yeah,
he goes to a bar and he drinks.
Yeah, and then sweats.
Then sweats it out.
Hard at that drinking. Yeah,
like a bicep curl.
What's a bar class? What's a bar class?
I think it was developed by someone who knew ballet, and so there's a bar in the class
I see. Yeah,
that you can kind of put your foot up onto or hang off of, and it facilitates different types of exercises. But it's a core workout.
Wow, way to go! You're looking even handsomer than usual.
Oh, why? Thank you. You too. I'm loving your goatee.
Yeah, thank you. Yeah, I think in my old age, it softens the blow a little bit. Yeah,
looking great. You too, Rhonda.
Thank you.
Thank you. I have lost 12 pounds too.
Oh, wow.
Yeah.
Nice. Nice.
So, it feels so great when your patients reach this level of enlightenment and understanding, and you see the light bulb goes off in their head, and they're like, oh yeah. Even when we're going through even positive reframing, when in the beginning, when people are like, now what does my depression say about me? That's awesome. I can't think of anything and then to get to the place where like, oh my gosh, really having a clear understanding of how beautiful their symptoms are. That feels so great.
Yeah, absolutely.
And it also feels actually even worse when patients are stuck and they're not getting better. It's depressing for me too. And it makes me feel really irritated with myself and lacking confidence.
Yeah, sure.
So, reading over this outline that you wrote, David, is really helpful.
Yeah. One thing I've gotten from a number of therapists is that they're angry with me. They say, I've listened to Dr. Burns, and he always gets, a cure in 1-2 hour session. And what's wrong with you? And they say this to their therapist that, I've been working with you for weeks or months, and I'm still having symptoms. And how should a therapist respond to that type of statement, or what should David do differently? Because it's certainly not the case that everyone's going to recover in a single 2-hour session.
Well, what I say when my clients or patients say that to me, I say, David Burns created this technique. David Burns has been working for 40 years. He's seen 40,000 patients and had 100,000 patient hours. And he's a lot more skilled than I am. And, he can do things that the average therapist can't do.
You can add, and he's a bit of a god.
Next time I'll add that.
Yeah.
But I do say you do things that other therapists can't do. And too bad you can't treat everyone in the universe, but that's not possible.
Yeah. It's just, does that happen to people say that to you often? Because I feel bad and kind of ashamed. No. And
honestly, no, not anymore. No, people don't say that to me often. What about you, Matt? What do you say?
Well, I kind of appreciate that someone would bring that up and talk about it with me, that they're feeling probably frustrated and pressured to recover in some certain number of minutes or something, and then when that doesn't happen, it causes some confusion about, are they doing something wrong? Is there something wrong with them? And they might be feeling, inferior or defective or something. And then they also could think, well, maybe there's something wrong with Matt, and maybe he's holding back, or and I just think it's a great conversation to have.
Yeah.
Like you said, David, if when you're failing with a client, it's an opportunity in disguise to really understand the nature of that, what it's like for them, and it often sets us back on course and creates some opportunities for us. It's much better than if they never talk about it and just leave therapy. I think that's the outcome that I like the least, is when a patient just drops out and I never hear from them and I never understand why they left therapy. Yeah. And I really worry about them, because I worry maybe they'll take that experience and think, oh, I guess I'm just a hopeless case. I didn't recover.
Yeah, that's right. Yeah.
In 2 hours or something.
Yeah.
But I can never predict how long it'll take for someone.
Yeah, that's right. That's right. And it depends on the kind of problem, too. People with relationship problems and habits and addictions always take much longer. It's not because the techniques aren't as fast and effective. The techniques are equally fast and equally powerful for relationship problems and for habits and addictions. But the resistance within patients is far more intense, and the ambivalence. And maybe a person is eventually going to make the decision to leave their spouse, but they may take them 2 or 3 years to come to that conclusion. And so those things are harder. But when I was young, I used to worry. And then I stopped worrying about patients that are taking a long time to get better, because it's only in my older years, my elderly and half demented years, that the speed of my patient recovery seems to have gone up to where it is now. And it's fun to have that skill, but I worked for it for the last 40 or 50 years, and I didn't always have it. And in the early days, what I used to do is to tell myself, when I had a patient who was taking 6, 8 months or whatever and feeling hopeless, and I just told myself, I'm never going to buy into the idea that they're hopeless, and they will always recover at the exact correct moment. And they won't recover a minute before they're ready or a minute after they're ready, but it is going to come. And then if the patient didn't fire me, if they stuck with it, that pretty much nearly always happened, that we would finally find the thing that worked for them. But it used to frustrate me also, and wonder, why it was taking so long, and maybe Aaron Beck would have gotten much faster results or something like that. But then I finally just decided to stop worrying about that and keep learning as much as I could, and not fretting about it, and just feeling the tremendous joy when that moment of recovery finally does come for a person.
Well, I had a case where I had a very stuck patient, and I believe that even though I was trying to follow what I was trained in graduate school were the best practices interwoven into team, I definitely failed him. And I just realized Jill talked about this in one of the Tuesday group nights, that, we would start on one issue, like, for example, depression or anxiety, and I only see people for an hour. So we would do something, but not complete, like the entire structure, not complete the agenda setting. And then I'd say, okay, well, next week we'll pick up right where we left off. And the next week, this person would come in and say, well, I want to do something else. I want to talk about my relationship, or I want to talk about something else that's happening, or a different moment that was upsetting to me. And I was taught in graduate school, you go with where the client wants to go. You follow the client's lead. So I always said, okay, and then we'd start something and not finish it. And I'd say, well, next week we're going to finish this one. And then we may go back to the first one. And, he became frustrated, and I realized, I'm not doing something. This is not working. And then somehow Jill talked about it in the Tuesday group, that when patients come to you and they do that pattern where they bring up something else, that it's really our responsibility to say, that's an awesome thing to work on too. And I can tell that that's really important, but we really need to finish one issue or one concern that you have from start to finish before we move on to something else. And I think if I had done that, it would have been I know that it would have been a much more successful, therapy journey for him.
Absolutely. That's absolutely right. We need whatever we're going to work on. We're going to work on that thing. It might take us 6 sessions, and you're going to be doing homework between sessions. And then once it's done, we'll go on to something else. If you need something else, you probably won't. But if you want to keep changing each session, I would encourage you to keep doing that, because I can guarantee that nothing will change. And I like you, and you're a full fee patient. And so that will guarantee a nice income for me. But in case you're interested in recovery and getting back to joy and great relationships with others, let's just focus on one thing and take it through from start to end, and then see where you're at. And that I'll have to add that to the outline too of why therapy fails. I had heard a horror story. Well, not a horror story, but kind of a horror story. On Sunday, I was hiking. I won't mention the name of it, but with a really jovial and really nice therapist who had been coming to the Tuesday group for quite a while, but I'd never had the chance to meet him personally because he lives at great distance, but he happened to be in town. And so I said, well, let's put together a little Sunday hike at the last minute. And Derek Gurney came along too. I hadn't seen him for a couple of years because I cut out the Sunday hikes because of COVID, and then because of this back pain that I got. But anyway, we were walking along, and he said that in his years before he ever went into becoming a mental health professional, he did a lot of different jobs, and he had some issues. So he went to a psychoanalyst, and he had very little money, and he lives in a country where people tend to be much poorer than in the United States. And the analyst suggested he come 3 times a week on the couch for free association. And this went on for 15 years.
Oh my gosh.
And the analyst would sometimes do dream interpretation or things of that nature. And after 15 years, it occurred to him that he had been having panic attacks and all kinds of specific things he wanted help with, relationship issues and whatever, probably a list of things he wanted help with, and that he hadn't gotten help with a single one of them, that nothing had changed, even to a small degree. And so one day he decided to tell his therapist that he felt that he hadn't been getting any help at all. And that maybe we need to talk about that, and I'm sure he probably presented it in his own version of it, but he said that she became enraged and told him to get out of the office and never come back, and made some kind of psychoanalytic interpretation, and kicked him out of the office, and he never saw her again.
Oh my gosh. How punitive and nasty.
Yeah.
That is a horror story.
Yeah. But I just personally do not have positive, optimistic thoughts about the quality of therapy. I mean, I shouldn't sound like an old grunge. I'm getting old and bitter and impossible to get along with, or horrible to be around in my elderly age. But I'm just kind of skeptical and cynical about the quality of our field, broken up into all these cults and people with all their gurus and their followers, and not measuring things. And I don't think it's healthy. I don't think it's right. And so that's why I speak up, and that's what we're trying to do with TEAM, is not start a new school of therapy, but a structure for how therapy works in a systematic way to individualize treatment for each person, to get data, to find out what's working, what's not working, and that when things aren't changing, to have a checklist to go through and see, am I failing in empathy with this patient, and am I using the wrong methods? Maybe I'm using the right methods but for the wrong problem. Like maybe the patient has a relationship problem and I'm trying to cure them with the daily mood log. When they use the relationship journal, there's a lot of specific errors that people make. And if you're humble and willing to identify that you are stuck with certain patients and find out why, and then make a correction to your error, then you can turn the therapy around. We offer unlimited free psychotherapy and personal work for therapists. In my Tuesday group at Stanford from 5 to 7 every Tuesday night. You can come via Zoom, or Wednesday, Rhonda's midday training group and team CBT. And we have a lot of resources for you, but the first step is to start using the assessment instruments, the brief mood survey, and find out how you're doing and find out what your empathy scores are. And the second is to have the humility to want to improve. And then, ask and you shall receive is a biblical statement, and it's one that I've always believed in. And if you have the humility to ask, and, we certainly are willing to help and teach you. But I would also caution you that team is hard to learn and takes tremendous commitment. I have a question for you too. My friend Jeremy, who Matt, and Rhonda, I think you know Jeremy.
I know Jeremy.
Is thinking that the name Team CBT is kind of dorky, and team sounds kind of bland, and people don't know what it means. And he's suggesting we use something sexier like rapid CBT or high speed CBT. Any opinions? I don't want to.
I mean, I love Team CBT. I love that each letter is an acronym for what's part of the therapy structure. I love that, we are a team, you and me and you, me and and the client, and you're not working on your own. And I don't know, it feels very collaborative and warm.
Yeah.
What do you think, Matt?
I like team. I don't know. Maybe it's just something I've gotten attached to, but it does help me a lot just to be able to structure my thinking if I'm stuck. Go back to different elements and try to figure out what's going wrong in the therapy and how to get it back on track.
Cool.
Yeah.
Thank you.
I'll leave. Jeremy's like a marketing genius. I think he'll figure out a good answer there.
Yeah, he's good. That's for sure. Smart fellow.
I was thinking of something that contributes to stuckness, and that's the lack of the patient or client doing homework, and the inability of the therapist to deal with that.
Yeah, to make the patient accountable. That's huge.
Yeah, to make the patient accountable, to not be punitive, like that person you just described, that their psychoanalysis was really punitive, or be judgmental, or icky about it.
Yeah, absolutely. And you have to make patients accountable at the initial evaluation. That's why I wrote the concept of self-help memo. Have them read it and realize if you come to me, homework is going to be required. I'll still listen. You can talk, but you're going to have to identify problems you want help with. And we're going to teach you techniques to solve those problems. You're going to be practicing those techniques for homework. And if you do that, and if we collaborate together, it's be practically impossible for us to lose. And if you're unwilling to do the homework, it'll be impossible for us to win. And I'm thinking then I wouldn't be the therapist you should choose. You should go to someone who will allow you to just talk and come to sessions and talk. And maybe that will lead somewhere. I can't say, because it never once worked for me. For a patient to do. I did a lot of listening and having patients talk when I was a resident, and I never saw any improvement from it. But that's such a common reason for stuckness. And there again, the therapist, it's usually due to therapist codependency, narcissism, or excessive niceness, not wanting to make the patient accountable. and that's huge.
Absolutely.
Super huge. Yeah. Go ahead, Matt.
Yeah, and it's always sad when we present that as something that would be required for recovery, in the same way that you'd have to practice the piano between piano lessons if you wanted to see improvement. But the alternative is after years of piano lessons, they can't play the piano, and that's even more discouraging and upsetting. So I think it's so important to kind of make it clear that that's part of the process of healing and recovery.
Yeah.
One other variable we could talk about is the dosage of psychotherapy, and um, it may be somewhat related to what you were describing there, Rhonda, that in an hour's time, I very seldomly see radical changes in a person's mood state. But in a 2-hour session, it's rare for me not to see radical changes, and I think it requires some time to kind of get in sync with our patients and identify what the problem is we're going to work on. And if you're only meeting an hour per week, by the time you kind of catch up on what happened that week and remember what you were talking about and get back to it, the session's over. And I liken that a little bit to like trying to boil water one match at a time.
Oh yeah, that's
and
cool.
And if we want to get change to occur, we've got to have an intensive type of treatment.
Yeah.
And that's where I see the most radical change occurring. When people commit to doing 2 hours a day for several days in a row. And
I love that.
Really powerful results.
Yeah. That is so beautifully stated. Do you think it costs more to have a double session, to see patients with double sessions?
No, it will save them a lot of money in the long run. And all my clients who've tried both will, with maybe an exception of folks who have a very short attention span, will say that a single 2-hour session is as valuable as 3 or 4 or 5 1-hour sessions.
Matt, how do you introduce the idea of a double session to your clients?
Kind of like this, kind of the way I'm talking about it right now, that I've just seen such great results when we're doing that. I do let people know that it's usually not reimbursed by insurance companies. Insurance companies haven't caught on that this is an excellent model and would actually save them money too if they were to endorse it. But most people can't get reimbursed for more. I think this is still true, more than 1 hour psychotherapy per day.
Can I talk about a time I had to treat you for feeling terribly down and out, Matt?
Yeah, which one?
Related to what you were just saying, because I remember not that long after you'd started your practice, you asked if we could do an extra hike. And I said, yeah, sure, come on over. And I remember we went up, we went to the right and then went up that road. I can remember the path we took. And I think we met some guy and talked to him about his dog, or that a lot of the coyotes seem to be dying of some disease or something. It's just memory traces. But the thing that you were really sad about was that you were having trouble paying your bills because your patients were getting better too fast after 3-4 sessions, and you were really in a panicky and discouraged state. And I think that's the other half of the 2-hour sessions. You can get to where people get well so quickly that the therapist kind of gets punished in a way. And then I said, well, Liz, we'll just send a note to the Tuesday group and tell everyone, I'm sure you'll be filled with patients in no time. And I think that happened. But can you recollect back on that and tell us how it evolved over time?
Yeah. Actually, you helped me a lot with that. I think that may have also been in part my social anxiety. It's hard for me to reach out and say, hey, I need more patients or something like that. But I think that's a totally appropriate thing to do if you're a therapist and you start to get rapid results and then suddenly you don't have patients. That's a problem. But if you've got those kind of awesome skills, reach out, let us know, and we'll send folks your way. And advertising really helped. And so, yeah.
Do you have enough patients now, Matt? I mean, if someone listening to the show wants to go to one of the world's top 5 psychotherapists, would you have room to take them?
I always have room in my practice. Yeah. People are getting well rapidly. And so come on by if you're wanting some help. And I'm really enjoying doing training these days too. So if you're a therapist who's stuck, I also really, so I have a couple groups.
Right. And suppose they instead wanted to go to the Feeling Great Therapy Center. I've heard of that. And I've heard they've got some great therapists there, Brandon Vance, Heather Clegg, a lot of others, and this Rhonda woman.
They're actually even better than me. I would definitely recommend them first.
But anyway, if you're looking for help, we put contact information at the bottom of all the show notes. And then we had one on, free options too, a great podcast, not maybe 2-3 months ago. And so we have a lot of options for you. Well, thank you so much. Any closing words, Matt and Rhonda? Let's start with Rhonda, and then we'll give Matt the last word on therapeutic stuckness.
I just really appreciate being on this podcast with both of you, and Matt, whenever you, and of course you too, David, whenever you share something or expound on something I learned, as well as the people who are listening. So it's really a joy and an honor to be a part of it. And I think what you're bringing up is something so important for therapists to talk about and think about. And when they're stuck, what's happening? Do they need to reach out to someone for support, another therapist, or for a consultation, and really figure it out so that the stuckness doesn't last forever, for both their sake and their patient's sake, right?
Awesome.
Okay, top that, Matt.
Well, I can. I'm not sure what to say, but I remember I had a wonderful supervisor at Stanford. Several. David, you shaped me and helped me the most. Another was Jose Maldonado. And he had a really brilliant metaphor for how therapy can be kind of like trying to get a sailboat to go. That there are all these confusing contraptions and ropes and sails and wind directions and the rudder, and everything has to be kind of just right for it to take off. And so it's easy to get kind of stuck in the water and frustrated and to think, oh, I'll never be able to get anywhere here. And then if you just go through that process of, trying every different variable and working on it and getting help if you're stuck, getting another opinion, someone who's got a lot of experience, then pretty soon you'll be on your way.
Right. And then my last question, and I'll ask each of you, if I'm a therapist and I'm stuck with my patient, why is that? What am I doing wrong?
You go first this time, Matt.
I have no idea, but I'm excited to talk about it with you. What was a moment in time where you felt stuck with your patient? What were they saying? And what did you say in response?
Sure, that's a great method, but that's not the answer. Let's see if Rhonda can come up with the answer.
Well, you just described 25 reasons, David, and then I added the mistakes that I've made.
Yeah.
And so I'd have to say, talk to someone again. There might be needing time for reflection, self-reflection, and to really just think about what is happening in your your work with the client to figure out where the stuckness is.
Sure. Well, that's a good answer. Blah, 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 blah.
Okay. Well, you give us the answer.
But there's only one correct answer, and that's 99% of the time it'll be an agenda setting error.
Oh, right.
That you're trying to help someone who's putting up resistance.
Yeah.
And that's where you need to learn, the 4 forms of outcome resistance, the 4 forms of process resistance. That's where all the money is. All these things can be important, but and to learn that, you really need to come to Rhonda's group or David's group or one of Matt's training groups, Do you have training groups for the general therapists, or there's only Stanford-related people, Matt?
For both. Through the
Oh.
Feeling Good Institute, we have an advanced group, and then I'm have a group for the Stanford residents.
Well, send those links to me so I can add them to the show notes.
Sure.
Matt, don't you have a group with Jacob Towery?
Yeah, that's the Stanford-oriented group.
And that's only for residents?
It's not only for residents. In fact, we're thinking of including some people who aren't actually therapists but are just interested. They do see patients and are interested in applying the team model in their work.
Awesome. And that's every other Monday at the Stanford campus. And how, if somebody wanted to join, would they join?
Yeah, I'll send the information to you so you can.
But tell us, say it in case they don't read the show notes.
Yeah, it's at Palo Alto University. It's from 5:30 to 7:30 every other Monday evening.
And would they email you?
They could email me or Jacob Towery.
Okay, so you'll send us that info and they can find your email in the show notes. Fantastic. Okay, well, thank you, folks. And thank you for listening, and looking forward to next time, as they say.
Yes.
And I don't know who they are, but they do say that.
Great spending time with you both.
This has been another episode of the Feeling Good podcast. For more information, visit Dr. Burns' website at feelinggood.com, where you will find the show notes under the podcast page. You will also find archives of previous episodes and many resources for therapists and non-therapists. We welcome your comments and questions. If you want to support the show, please share the podcast with people who might benefit from it. You could also go to iTunes and leave a 5-star rating. I am your host, Rhonda Borowski, the director of the Feeling Great Therapy Center. We hope you enjoyed this episode. I invite you to join us next time for another episode of the Feeling Good podcast.